Hey, this is Gonzo Gonzalez, and this is Dr. Gonzo's Talking Points. Today I'm going to be talking to you about what aortic valve stenosis means. Most patients that come in to see us with aortic valve stenosis have what we call congestive heart failure, and that is one of the three cardinal signs associated to aortic valve stenosis. The other two are chest pain and fainting episodes, and that completes a triad, or the three cardinal symptoms associated to aortic valve stenosis. When people have aortic valve stenosis, the issue is not only their symptoms, but once we can tell that they have symptoms, we can kind of predict how long you're going to live. For people who suffer of chest pain associated to aortic valve stenosis, we typically tell them that about 50% of people that have the disease will die within 5 years. If you have fainting as your cardinal symptom, then the chances of being alive drop to 50% in 3 years. And the worst sign to have or symptom to have associated to aortic valve stenosis is congestive heart failure, which portends the poorest of all conditions or symptoms. And people can be categorized into a survival of about 50% at 1 or 2 years. That's why therapies like TAVR and open surgical replacement are so critical for that patient population, because we can not only change their symptoms, but we can actually help them live longer. Patients that have aortic valve stenosis typically have what I call, instead of a big open door, a pet door. And so if you can imagine in a room, blood trying to leave that room or the heart, and what happens is that blood starts backing up. It backs up to the place where it came from. That location typically is the lungs. If blood starts pooling into the lungs, then you have shortness of breath. And that's the reason why people develop congestive heart failure, have symptoms of shortness of breath associated to congestive heart failure. Now, therapy for aortic valve stenosis have evolved over the years, and in the past, it was solely relegated to open replacement. But that has gotten better over the years, and now we're offering people minimally invasive procedures to try to alleviate the aortic valve stenosis. The two options right now that we have in the market are, number one, a minimally invasive aortic valve replacement that could be done either through the right chest or a mini sternotomy, and then there is TAVR. Now, let me talk about aortic valve replacement through the surgical approach, through a mini approach. The reality about it is that the mortality associated to isolated aortic valve replacement is about 1% in experienced hands. So really, 99% of people that have aortic valve surgery don't die from the procedure. There are other complications associated to surgery that include, but are not limited to, stroke, bleeding, infection, and kidney damage. The chances of developing any of those can range anywhere from 4 to 5%. So overall, open surgery, whether through a minimally invasive approach or through the standard approach, is well tolerated, and people can really enjoy a long-term benefit associated to that. And it's a standard of care which we compare all other types of minimally invasive and catheter-based surgeries that are out there in the market. The procedure typically takes about an hour and a half. The process of surgery, it's about 6 hours. And you spend about a week in the hospital thereafter. Now, what's happened over the last 10 years is that we have developed catheter-based technologies that have allowed us to replace the aortic valve using a catheter through a groin approach. And that's what we call today a TAVR, T-A-V-R. And what it is basically using a catheter, just like they do a catheter when they do a coronary angiogram. We can actually then deploy a valve on a catheter into the aortic valve without having to open up the chest. Now, the trials that have been created and that they're out there have allowed us to do this in high-risk individuals. Those are people that wouldn't be candidates for conventional open surgery, because the risk of dying from those therapies is higher than that of the benefit that you would gain if you would have your aortic valve replaced. So therefore, what we do nowadays is we start offering for people that are not candidates for surgery, TAVRs, and that's an FDA-approved procedure. Now, not everybody is a candidate for TAVR, and as I said, you have to be you can't be a candidate for surgery, or you're determined to be a high-risk candidate for surgery. those are the patients that usually we relegate to TAVR nowadays. Now, there are studies going on studying TAVRs in low-risk patients that would conventionally tolerate surgery, and also another group of patients that is called intermediate risk patients that basically are not can be candidates for surgery, but they're a little bit of the higher risk, and so we would definitely recommend that they probably go TAVR. The key thing about all these technologies is that it's better served for patients that go to valve centers, centers that have a group of individuals that can evaluate the patient and determine whether there are good candidates for the therapy. In Fort Worth, we have that particular program, and every case is basically evaluated by a number of individuals that then decide what is the best course of action. And let me tell you, sometimes the best course of action is to do nothing, particularly if we believe that the patient is too high risk for any of these procedures. So anyway, that is the current state of affairs when it has to do with aortic valve stenosis. I hope you continue to listen here at the Ask Dr. Gonzo Anything channel. And this is Gonzo for Talking Points. Thanks for listening.